So, how is breast cancer diagnosed? I am Dr. Wolf. I am a pathologist, and I have diagnosed more breast cancer than any other type of cancer. Yesterday, we talked about the anatomy of the breast. So, if you haven't seen that, please go back and watch that video because it is essential to understanding how we arrive at diagnosis. So, how do we get to the point of needing to diagnose? There's really two pathways. The first is that you have a symptom. The patient has a symptom, most commonly something like a mass that they have felt in their breast, but you can have other symptoms such as changes in the skin, nipple discharge, feeling a mass in the armpit, things like that. And then the other is when something has been detected on imaging. So this would be something like a mammogram that shows an abnormality or some other type of chest imaging that shows an abnormality. When that happens, the only way to definitively diagnose is to take a sample of that tissue. And when we talk about sampling tissue, that is when the pathologist becomes relevant to the case. These core biopsies are typically done by radiologists. There is a procedure known as fine needle aspiration or fine needle biopsy, which can be done by pathologists. I'm not going to cover that here, nor am I going to cover surgical excision, which is given to the pathologist for diagnosis. Those are going to be separate topics. So this is what a core needle biopsy looks like. Okay, first of all, let's go up top here, and you can see that these are somewhat cylindrical in shape. They, even though there's no size reference present, these are about 2 to 3 centimeters in length, so around an inch, and then they are about 3 to 4 millimeters in width. So we're talking like a 16th or an eighth of an inch, something like that. Now, this biopsy is, when it comes to the pathologist, we do describe these. It's called a gross description. Now, I can tell you from looking at this one that there is some abnormality. Whether that is cancer or not, we won't know until the microscope. But this is very dense tissue because it's tan white. You usually see that with things like dense fibrocystic change. You can see that with fibrosis or scar. And of course, you can see that with cancer because it is either very cellular tissue or it is tissue with a lot of collagen in it. Now, if you can see at the end there, that yellowish part, that I can tell you is going to be normal breast tissue. And a breast biopsy that looks mostly like that is almost certainly going to be normal. So the biopsy is taken and it's placed in formalin, which is a formaldehyde solution, a fixative for the tissue. This makes it easier to cut the tissue for the histologist, and also we need this fixed in formalin for cellular markers like estrogen receptor and progesterone receptor, things like that. Now we can see just from looking in this, the density is different. One is sort of floating, so it's lower density, and another is sunken and is higher density. And so that can be a clue. With higher density tissue, you do tend to worry a little more about malignancy. Now, once the pathologist is finished looking at it grossly or macroscopically, they place it into these green cassettes. Now, not all cassettes are green. Some are white, some are blue, and some are pink. But they place it into these cassettes and it is placed into a processor, which runs through a series of chemical and heat related changes that results in fixation, which makes it very easy to cut that tissue. And you can see this kind of white gray material. That is paraffin. It is wax. So the tissue is embedded in wax, and then it is placed on something called a microtome. If you break that word down, it means small cut. And that's because each time the histology technician turns the crank on it, it will cut something like 3 microns, 4 microns, 5 microns thick. A micron is a thousandth of a meter. And so what happens is they take those little slices that are embedded in wax, they then can put it on a glass slide, and then they can stain it. And that's what we see up here. These are all stained with hematoxylin and eosin. Okay, this, if it's very purple like this, that means there's a lot of cells present. A lot of cells present can be worrisome for cancer. And looking under the microscope, I can tell you that this is invasive ductal carcinoma. And I'm not going to go over the specifics too much of diagnosis here because we're going to do more detailed videos on that. But when we say ductal, means of the duct. A duct is, of course, a tubular structure. Please go watch the anatomy video that I posted yesterday to understand this a little bit better. But these next to my head there and here, those are ducts, and they are haphazardly arranged, okay? And there's a lot of fibrosis kind of in between these ducts. That's that pinkish stuff. And that is a cellular reaction. That is a tissue reaction to cancer. So we look at this and we know that this is a kind of well to moderately differentiated adenocarcinoma of the breast. Now, with this tissue, we can go ahead and run the stains known as estrogen receptor, progesterone receptor, and HER2/neu. Those three determine the treatment strategy of the oncologist and the radiation oncology team and the surgeon. So, this is just the biopsy. It's a multidisciplinary team involving the pathologist, but also, like I said, oncology, radiology, and surgery for us to come up with a plan to how to treat this in the next phase. And so we will go over those next phases, such as an excisional biopsy. I'm going to show you a little bit of what that is like tomorrow.